This is going to be Chapter 2, Pharmacokinetics and Pharmacodynamics. Introduction. Drugs take a complicated journey through the body before they produce their desired therapeutic effects. They have to go through the circulatory system, they have to make it to the actual site where they're working on, or the receptor site. They are eliminated from the body, and once the drug reaches its receptor sites, biochemical and physiological actions occur. And then the pharmacology effects are called the drug's mechanism of action. So we're going to talk about all of these aspects in this slide set. So the first three things are definitions. First of all, pharmacology, which is the study of drugs and their actions on the body. Next term we're going to learn is pharmacodynamics, mechanism by which drugs produce biochemical and physiological changes in the body. So these are going to be actually where the drugs themselves are working on the physical sites and what kind of changes that they bring about, or what kind of changes do they perform to bring about the actions. And pharmacokinetics, a study of the basic process that determines the duration and intensity of the drug's effects: absorption, distribution, biotransformation, and elimination. The drugs have to be absorbed. They have to be distributed to the receptor sites. Biotransformation has to actually occur, and then they start their elimination process out of the body. And from that, we get something called the Therapeutic Index, and we'll talk about that too. Physiology of transport. Pharmacokinetics is dependent on the body's various physiological mechanisms that move substances across the body, and we have multiple areas of transport here. First of all, active transport, which is an example of this would be the sodium-potassium pump, requires the use of energy to move a substance. The next one we're going to talk about is carrier-mediated diffusion or facilitated diffusion. A molecule binds with a carrier protein, allowing larger molecules to move across the membrane. An example of this would be insulin on the surface of the cell, facilitates the diffusion of sugar into the cell. Passive transport, or diffusion and osmosis, does not require energy for movement of molecules. Molecules move from an area of higher concentration to an area of lower concentration. Diffusion involves the movement of solutes in a solution, where osmosis involves the movement of a solvent, usually speaking about water. Drug absorption. Drug absorption encompasses a drug's progress from pharmaceutical dosage to a biological available substance that can pass through or across the tissues. And the factors on absorption, or the ability to absorb the drugs, pretty much work down to these 5 categories here. 1, what is the patient's circulatory status? Do they have the ability to get the drug to the actual receptor? And solubility. Body pH, concentration, and bioavailability. And we'll talk about these here in the next slides. First of all, circulatory status. Poor circulation results in slow drug absorption and therefore delayed or inadequate therapeutic response. Drugs can be given via intravenous route to bypass the absorption process. That way they directly hit the receptor site. An IV administration technique permits the drugs to go directly into the circulation, thereby permitting a faster therapeutic response. Solubility of the drug. The drug's ability to dissolve. The higher the solubility, the faster that it enters the actual bloodstream. So if the drug dissolves and becomes soluble and becomes to where it can be active, the quicker that it does that, the quicker it will get in the bloodstream. Body pH. Your body only works at a pH, or a hydrogen ion concentration, of 7.35 to 7.45. Acidic drugs tend to move more rapidly absorbed when they are placed in an acidic environment. An example of this would be the stomach. And alkalinic drugs are more rapidly absorbed when they are placed in an alkaline environment. An example of this would be the kidneys. Concentration of a drug. Drugs given in higher concentrations are absorbed much more rapidly. That's because you kind of overpower them, the actual environment that it's working in. So the more drug that you actually place into the patient, the quicker you'll get a response. The higher the concentration, the quicker the absorption. Or the more that you give, the quicker it gets in. Bioavailability. The rate at which the drug enters the general circulation, permitting access to the site of action. And this is determined by the measurement of the concentration of the drug in the bodily fluids, or by the magnitude of the pharmacological response. So if you have a drug that's very, very potent, you could have a bigger pharmacological response. Or if you have a higher concentration of the drug, you can get it into the body fluids faster, and this would make it more available quicker. Comparison chart of absorption rates. So when we look at oral, we get very slow absorption rates here, but say intramuscular would be moderate, sublingual, endotracheal, rapid, interosseous. This would be just like putting it in the bone to where it gets in the central circulation. This would be immediate, intravenous immediate, intercardiac immediate. So comparison of the actual absorption rates, or when the actual drug is available. Distribution. The entire dose does not travel to the targeted tissues. Drug travels throughout the body, and it may bind to blood proteins that are floating around. Example of this, the highest protein content in the blood plasma is albumin. Can be stored in fatty tissue and concentrate in well-supplied blood tissues. So the more blood supply, or the more concentrated the blood supply, the more that the drug can actually concentrate there because it's flowing there more. Physiological barriers. We have two physiological barriers that we are concerned with as far as pharmacology. Physiological barriers inhibit the movement of certain substances while permitting the passage of others. There are two main barriers, and they are the blood-brain barrier, which allows certain drugs to cross between the blood supply and the brain tissue, and there's the placental barrier, a barrier between the mother and the unborn child. And we worry about both of these as far as pharmacology is concerned. Biotransformation. Biotransformation is a process of breaking down or metabolizing drugs in different chemicals. Biotransformation has two effects on drugs. Transforms the drug into a more or less active metabolite, or it transforms the drug into where we have a working product, if you will. That active metabolite would be something that would actually work on the receptor sites. Make a drug more water soluble and less lipid soluble to facilitate elimination faster. Some drugs are totally metabolized, lidocaine, before elimination. Others are only partially. The body will transform some drugs and eliminate others without changing them. This process begins immediately following the introduction of drugs into the body. The liver. Endoplasmic reticulum of the actual hepatocytes contains macrosomial enzymes that perform much of the metabolizing. Smaller quantities of the same enzyme are found in the kidneys, lung, and GI tract. Blood from the GI tract first passes through the liver before moving to the body, and this would be through the portal circulation system. Many drugs are inactivated because of this. Many drugs give an IV to prevent the first pass-through effect in the liver and inactivation of the drug. So we give a lot of drugs IV due to the fact that we don't get this first pass-through effect, and the liver doesn't metabolize these drugs. The drugs that can be given IV or orally must have a larger dose when given orally to counteract this effect. You must give a larger dose because some of it's going to get diminished as of the point that it goes through the liver. Elimination. Drugs are eliminated either in original form or as metabolites. Elimination routes. The kidneys are a big eliminator into the actual urine. The liver into the bile, and the bile is excreted through feces. Intestine in the feces, lungs in the expired air, sweat, saliva, and breast milk, and artificially through hemodialysis or peritoneal dialysis. The rates on this elimination vary with medication and the state of the actual body. During shock, kidneys are poorly perfused, and drugs eliminated by them will remain in the body longer because the kidneys are not getting perfusion and do not have adequate filtration rate. Disease factors and general state of health must be considered when giving an actual drug. Elimination can be affected by the following. The drug half-life. So if the drug has a longer half-life, example 120 days, we worry about it sticking around for 120 days or almost 4 months. How long will the drug remain in the body? And the total amount of drug is diminished by 1/2. So after this drug has hit its half-life, its effectiveness is decreasing after that. Accumulation. Time to required to reach the loading dose. Time required to reach the loading dose. Too long, start with the loading dose to reach desired therapeutic effect, and then lower dose to maintain. So how much drug have we actually accumulated in the body? We know, or we will know, if we don't know already, that we have something called a therapeutic index. So what we should try to do is to be therapeutic or to be effective for what we want the drug to do, it needs to rise in the body and stay there for X amount of time. Clearance. Removal of the drug from the body. Very simply, at the point that the drug starts its half-life process on the way down, the body starts clearing off the medication like a toxin. So slow is removed slowly and fast is removed rapidly. So if it has a very fast clearance, the drug will completely be gone from the body's recognition quite quickly. And then onset, peak, and duration, which we'll talk about in the next slide. Onset of action. And the onset of action is exactly what it says, when the actual drug has sufficient enough levels or it's been sufficiently absorbed to reach an effective blood level in the body and sufficiently distribute to its site of action to get a therapeutic response. The onset of action means that the drug has actually risen high enough. There's our therapeutic level that we would like to have, and now it has plateaued off, and it will continuously give us that for this long. At the point that the half-life, if this started going down here, the half-life on this drug would be somewhere around right there, when half of the drug is gone. Peak concentration. Concentration of the drug rises in the blood. More drug reaches the site of action and therapeutic response increases. Duration. One drug begins to circulate, it begins to be eliminated. Once the drug actually begins to circulate, it begins to be eliminated. Eventually, drug levels absorption falls behind elimination and therapeutic benefits declines or stops. So this is just like that little arc that we've been showing you. That once it rises up, it has a specific amount of duration and then it goes away. This point, at some point in here, the pharmaceutical companies have figured out that if it gets below this level here, then the drug is not effective at all. So minimum versus the toxic dose, therapeutic index. Pharmacodynamics. Pharmacodynamics is a study of the mechanism by which drug dosages act to produce biochemical and physiological changes in the body. And the mechanism of action on drug, whenever this occurs, whenever we look at this, it pretty much binds to a receptor site. So it hits the actual receptor that the drug was intended, changes the physical properties of the cells, so now you get a product from this drug, and chemically combines with other chemicals, and alters the normal metabolic pathway. So from this drug, if this road was to continue straight, as soon as we got the drug, bam, we are doing something else. We are kind of offshoot of what the cell's normal function is. And we're hoping that since we understand what this drug does, that this will therapeutically do what we're wanting to do to the patient. Binding to a receptor site. Most drugs operate by binding to a receptor. Almost all drug receptors are protein molecules on the surface of the cells. Each different receptor name generally corresponds to the drug that stimulates it. The force of attraction between the drug and the receptor is the affinity. Different drugs may bind to the same site, but with different strengths. The ability of the drug to cause an expected response is its efficacy. So these are two terms that you probably need to know. One is affinity, and the other one is efficacy. So if I have a greater affinity, I'm drawn to it more. And if I have the efficacy of this drug is good, then it has good expected responses. Receptor site continued. Drugs bind to a specific type of receptor causes a chemical change to occur. A chemical change causes the drug to have its desired effects, or what you were using it for therapeutically. Examples of this would be if you're in pulseless arrest and I give you a dosing of epi, what I'm asking the cellular environment to do is to speed up or act like you've just been exposed to adrenaline. So if you have any fight left in you, please give it to me now. An example of this would be a heart that's in a systole or a pulseless rhythm that doesn't have the ability quite because of physiological problems to generate enough action potential to make a contraction. Very simply, the epinephrine just says, please give me all you got, or sends a chemical signal to the cells to say, please give everything you have. Most cases, drugs will stimulate or inhibit the cell's normal action. Drugs do not impart a new function to the cell. The cell will still do the same thing, but it may do it faster, more efficiently, and so on. Drug interaction with the cells may cause a release of a secondary compound, and most of these are helper proteins that we learned about in protein section of our A&P. Cyclic AMP, or cyclic adenosine monophosphate, was one of those. Is the most common compound and has multiple effects inside the cell. Cyclic AMP usually activates other enzymes which activate others. So this is kind of like, once we get this ball rolling, kind of a domino effect, and all we really have to do is tip that first domino. Receptor terminology. We have two key terms here that we'll use again and again throughout this course. And then the lock and key analogy, we'll kind of explain that. So the first term here is agonist. It binds to a receptor site and causes it to initiate a response. Agonist stimulates whatever receptor site that we are trying to attack or trying to affect. An antagonist binds to a receptor site but does not cause a response. Now the reason they use these terminologies is that as an antagonist may bind to the actual site, but it will not cause a response. It can actually even hinder the response. 3, lock and key analogy. So most of these drugs, whenever they hit the receptor site, are kind of a lock and key. The key may go into the lock, but not turn the lock, and might actually block it. It might unlock it, or unlocks but gets stuck in the lock and may only be triggered once. So those are your 3 options from a key and lock analogy. And this explains the key and lock analogy. So first of all, agonist alone, and this is going to be a stimulant. So if we stimulate this receptor site, we're going to get a product or full activation. If we have an agonist or a stimulant and blocking capability, this would both stimulate the receptor site but then block it from being stimulated again. So instead of everything happening again and again and again, we might just get one product that's not as aggressive, if you will, as the agonist product would be. And then we have antagonist alone. So antagonist would stimulate the receptor, and you would get a little response, but then for however long the half-life was for this antagonist receptor to be in place, you may not have a response from that receptor site, or you might not have enough energy here given off by the product to make activation of anything. Drug activity comes in 4 phases. We have the administration phase. Introduction of the drug into the body by the appropriate route. And then we have the pharmaceutical phase. Occurs after the drug is administered. The drug dissolves to be made available for absorption. And then we have the pharmacokinetic phase. Occurs when the drug is dissolved. Only free drugs capable of reaching the receptors can be said to exist in the pharmacokinetic phase. If you don't have a free drug, if you have a bound drug, then that drug isn't actually free and available for that receptor site. Pharmacodynamic phase occurs whenever a drug binds to its receptor site. So this is, very simply, I'm going to administer it. This is made ready for absorption. This is onset, peak, and duration, and the elimination. And then this here is whenever the physiological action that occurs, or the product, after it binds to its site. Say there's a receptor site, and we had a drug that bound to that receptor site. It's going to give us a product, or what we're thinking. Example of this would be a beta-2 agonist, beta-2 being the adrenergic receptor site that albuterol works with, and the albuterol stimulates it. That's going to give us a product of bronchial dilation, or that's what we're looking for anyway. If everything works as we have assessed, then we will get bronchial dilation off of that. Therapeutic Index. The minimal concentration of a drug necessary to cause desired response is the therapeutic threshold, or the minimal effective concentration. So that's the minimum amount available. Therapeutic threshold or minimal effective concentration. Concentration below this will not produce a clinical response or will not produce a therapeutic response. Differences between the minimal effective concentration, or the least amount of drug required, this line here, and the toxic levels, which may have an LD50 rating on it, And LD50 means it is a lethal dose in 50% of the lab rats. The difference between the two is considered the therapeutic index. Some drugs will have little difference between effective dose and toxic doses. An example of this is digoxin. Digoxin's therapeutic index is very small. Those are supposed to be nice equal lines, but you get the idea. So instead of a bunch of area and a bunch of room to move in, its therapeutic index is very small. Some drugs have significant differences between the two. So some drugs are like this. They have football fields in between them. You can give them lots of the medication before you even get close to the toxic dose. Administrative rates and therapeutic levels. So in this graphic here, toxic level would be this one, and the minimal therapeutic concentration would be right here. And this tells you in the different delivery types which one's going to last the longest. So the IV is immediately available. Whenever you give it IV drug, you get a high therapeutic dose and then it goes away because it's being eliminated immediately at the point that it makes its active metabolite or hits its receptor site. You start the half-life of the drug. And then you have the intermuscular, which has to go through a tissue bed, so it's going to stick around a little longer. And this is time. And then the oral version of it, which you have to give more drug for the same therapeutic response, but it lasts a whole lot longer than the IM or the IV shot. Pharmacodynamics Terminology. So, additive. The drugs together would have an additive effect, would be an example of this. The effect of one drug contributes to the actions of another. And we're going to talk through these here really quick. So that is what additive would. Antagonistic. The mutual opposition and effect between two or more drugs. So if the drugs are antagonistic of one another, they're going to kind of work against one another. Cumulative. The result of repeated doses of drug that accumulate in the body to produce symptoms of poisoning. So cumulative means every time that we add something, we have a little left over from the previous version. So this gives us more bang for a buck, or we had a cumulative effect. Depressant. Depressant is a drug that depresses the body's function. Habituation. The act of becoming accustomed. That to habituate to a drug is to develop physical tolerance to and dependence on the actual drug. Hypersensitivity. Hypersensitivity is the excessive susceptibility of the action of drug. So this here, if you're hypersensitive to the drug, what it means is it's going to take about a quarter, if not near the dose that a normal dosing would be. So you may be really hypersensitive to it. An idiosyncrasy. Accelerated toxic or uncharacteristic response to the usual therapeutic dose of the drug. So I give this drug, and instead of increasing the heart rate, it actually formed a lesion that looked like a plaid jacket on his leg. So that would be an idiosyncrasy. There's a fine line between idiosyncrasy and side effects. As the pharmaceutical companies are looking at this, if it occurs to a certain part of the population, a small portion, it's considered an idiosyncrasy. If it occurs to a good portion, or what they consider more than X%, then it is going to be a side effect. But the idiosyncrasies are something weird that it doesn't normally do. Irritation. Temporary tissue inflammation caused by the drug's action. Physiological action is the effect on the body function produced by the drug. Potentiation. Enhanced action of two drugs in which the total effects are greater than the sum of each drug's independent effects. So I give drug A and I give drug B, and if pain relief is my goal, then the cumulative effect or the potentiation of these drugs upon one another gave me more bang than each one of them individually. This would be A's response, or I'm sorry, B's response, and this would be A's response, and this is AB. So I get a lot more bang for my buck. Synergism. The joint action of two drugs produce an effect that neither drug could produce alone. So we put two drugs together and they are synergistic. So together they had a product that was much greater than either one. And there's a close verbiage on the synergism versus potential. Enhanced action of the two drugs is potentiation. One potentiated the other. And then synergism is like a known result or a joint action of the two drugs. Therapeutics. The production of favorable results from application of a remedy such as a drug in the management of the disease. So whenever we talk about being therapeutic with a drug, we're just talking about it's doing what we want it to do. Tolerance. The progressive decrease in the effectiveness or response of a drug. When you build up a tolerance to it, it will require more of the drug. An example of this. If you started taking narcotics quite regularly, it wouldn't be long before you developed a tolerance. The tolerance would make you have to take more of them for the same result. Untoward reaction. A harmful side effect of the drug treatment, and we can also put on here a surprised harmful side effect. So if we get an untoward reaction or an untoward effect on this, it is something that we did not expect, and it is something that was harmful to the patient. In conclusion, EMS needs to know when and how much of a drug to give. Understanding the basic pharmacokinetics, onset, peak, and duration, and the pharmacodynamics, how it's interacting with the cellular environment, is essential to knowing the desired therapeutic effects and anticipate possible side effects. Be aware of such factors as the drug's rate of absorption, how fast does it get on board, the minimal therapeutic concentration, how much of this do I need to get an effect, and the toxic levels. If I overshoot the effect, I'll need to know what those give me as well, and the possible and anticipated side effects. References for this were taken from Beck's Pharmacology for EMS Providers, pages 21 through 27, Delmar Learning, and Bledsoe's Pre-Hospital Emergency Pharmacology, 7th edition. The graphic used on slide 24 was taken from Wikipedia and Wikimedia and the following site. If you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smithr@imsa.net, or 405-219-7613. Thank you.